Hello, my name is Megan Licea, RN, and this is my presentation of AJM3 Task 1, Communicable Outbreak Assessment for Class D028, Advanced Health Assessment for Patients in Populations. In this presentation, I will use primary sources from the provided outbreak data as well as peer-reviewed sources to discuss these topics, which include the case definition of an outbreak, complete steps of an outbreak investigation, surveillance methods, case classification, the mode of transmission of this pathogen, and measures used in epidemiology to identify the parameters of an outbreak. I will also discuss an appropriate study design that accurately and clearly captures the impact of the outbreak, outlines the outbreak curve, and considers the incubation period for the disease. I will also explore control measures for the outbreak, as well as practical ways to disseminate information to ensure the relevant public remains informed. Finally, I will discuss what I have learned from this exercise, what I may have done differently, and how I plan to apply these concepts to my own clinical practice. At its foundation, a case definition asks, is there an outbreak? In other words, is there an increase in the frequency of a disease above the usual rate in a specific population or geographic area? These key components listed above help guide the investigation by asking these critical questions. Who was infected? Where were they infected? And at what point were they or may they have been exposed? How long did it take for the clinical manifestations to show up? Are there any criteria that can be used to either confirm suspect or probable cases or rule out potential cases entirely? In this scenario, the first person to show symptoms was Jack K., a 40-year-old man who just purchased property in the Four Corners area of the United States, which represents the southwestern portion of the country. In late July, after exploring his new property, he discovered initial symptoms of a red, itchy rash on his lower extremities. Shortly after, despite a fever of 100 degrees and flu-like symptoms, he visited 2 farmers markets where he encountered 200 people. The next day, Jack experienced swelling of the lymph nodes in his groin, difficulty breathing, and a productive cough. The next day, Jack was transported by 2 medics via ambulance to Golden Valley Hospital, where a further 480 people were exposed. On the third day, unfortunately, he succumbed to his illness. While this was happening, 73 participants at the farmers markets and 31 healthcare workers began experiencing similar symptoms, including the flu-like symptoms and lymph node tenderness, prompting them to seek treatment. Of this group, 62 of the farmers market patrons and all 31 of the healthcare workers would go on to fully experience symptoms of this outbreak. In the Crabapple Valley scenario, 10 critical steps are identified when investigating an outbreak. The first step is to identify the surveillance team. These team members typically include leadership, epidemiologists or physicians, nurses, pharmacists, statisticians, lab personnel, purchasing personnel, and public health liaisons involved in contract tracing, community care, and education. In Crabapple Valley, the surveillance team includes staff from Golden Valley Hospital, county public health nurses, laboratory scientists and techs, and epidemiologists from the state health department. Coordinating these efforts ensures that surveillance activities are proactive and responsive to the sudden rise in cases. Next, investigators must establish the existence of an outbreak. In this case, the number of patients from the farmers markets and healthcare workers from Golden Valley Hospital presenting with fever, malaise, and swollen lymph nodes exceeded the expected baseline for the region. The sudden increase in cases between August 1st and August 7th confirmed that this was not a sporadic occurrence, but instead a true outbreak of plague. Accurate diagnosis verification is critical. Blood samples and samples from swollen lymph nodes were sent for lab testing, which revealed elevated serum antibodies to the Yersinia pestis fraction 1 antigen. Although other diseases, such as COVID-19, Ebola, and smallpox, share overlapping symptoms, the hallmark presence of painful buboes, enlarged lymph nodes, and positive assays confirmed plague as the causative pathogen. A case definition is then constructed. For Crabapple Valley, individuals were considered suspect cases if they had attended the farmers markets or had been exposed at the community hospital on or after August 1st and exhibited symptoms such as fever, chills, cough, weakness, or swollen lymph nodes. A case definition provides consistency in identifying cases across a community. Case finding followed. For this outbreak, investigators created line listings that documented symptom onset, demographics, and exposure history. For example, residents of zip code 92307 reported 42 cases. These data points assist investigators in calculating the cumulative incidence of an outbreak. They also help with contact tracing and identifying clusters within specific neighborhoods. In Crabapple Valley, a retrospective cohort study seems to be a suitable approach for identifying common exposures, determining who is most at risk, and utilizing those insights to inform control measures, given defined exposure events in a clearly identified at-risk population. Descriptive epidemiology, including line listings and an epidemic curve, also known as an epi curve, adds to the analysis through visualization in terms of person, place, and time. The established hypothesis stated that individuals who attended the Crabapple Valley farmers markets on August 1st were more likely to develop plague compared to residents who did not attend due to exposure to infected fleas and subsequent person-to-person transmission. The independent variable was market attendance, while the dependent variable was the incidence of plague infection. Relative case calculations showed that exposed individuals were more likely to contract the disease, consistent with the elevated incidence observed in the community. Control measures, for example, risk reduction, were then implemented. These strategies include isolating confirmed cases, quarantining exposed individuals, and conducting public education campaigns. For example, residents were advised to reduce rodent habitats around homes and use insect repellent when outdoors. These measures strike a balance between disease prevention and public trust, a topic that will be discussed later. Findings are disseminated throughout the medical community in peer-reviewed articles or made available to those impacted by the outbreak in easy-to-digest ways with user-friendly language that is accessible by the public at large. Information is also disseminated to the public through informational town halls and press releases identifying causative agent as well as preventative measures. Surveillance is maintained by team members of Step 1 until the outbreak subsides. Documentation of the effectiveness of measures ensures accountability and guides future outbreak responses. Active and passive surveillance are two complementary approaches to monitoring disease outbreaks. Active surveillance methods include contact tracing, phone calls to exposed individuals, and a close review of reports and records. This approach is more resource-intensive as it requires additional staff and time. As a proactive strategy, this type of surveillance helps provide timely and precise information that can promote rapid intervention. In Crabapple Valley, active surveillance was critical in identifying clusters among farmers market attendees and healthcare workers. Investigators created line listings and symptom onset data to track the spread of illness. This allowed them to construct an epidemic curve and implement control measures. By comparison, passive surveillance relies on routine reporting tools such as hospital communications, school health reports, and provider notifications to public health agencies or the Centers for Disease Control and Prevention. While less labor-intensive, passive surveillance may provide limited information and can lead to a delay in recognizing an epidemic. When healthcare providers submitted records of patients presenting with fever, malaise, cough, and swollen lymph nodes, public health officials were alerted to the possibility of an outbreak in an example of passive surveillance. Suspect cases are an aspect of a case definition and consist of 3 parts. Individuals who exhibit clinical manifestations of the disease were at a common location at the same time and were exposed to a person with the disease. In the Crabapple Valley scenario, clinical manifestations include a fever greater than 100.4 degrees Fahrenheit, chills, weakness, and tender swollen lymph nodes. The initial location of exposure was at the Crabapple Valley farmers markets on August 1st, with secondary locations including the medical transport team and healthcare workers at Golden Valley Hospital. By these parameters, 73 people from the farmers markets, 2 medical transporters, and 36 hospital employees who reported symptoms corresponding to the clinical manifestations of the disease qualify as suspect cases. Jack, the index case, is also included, as he exhibited clinical manifestations after August 1st, bringing the total number of suspect cases to 112. While clinical manifestations establish suspect cases, epidemiologists base probable cases on positive diagnostics or tests. The CDC explains that taking blood samples or a portion of a swollen lymph node from a suspected patient and submitting these samples for testing is an effective way to diagnose plague. In the Crabapple Valley scenario, samples of sputum and lymph node were bacteriologically cultured to test for Y. pestis F1 antigen, and chest x-rays were examined for bilateral increased pulmonary congestion. After a positive x-ray and assay result, 62 people from the markets and 31 healthcare workers were diagnosed as probable cases of plague. Epidemiologists calculate cumulative incidence as the proportion of a population at risk that develops a new disease during a specified period, which is helpful for understanding the extent of the issue, identifying vulnerable groups, and directing effective public health interventions. Comparing cumulative incidence across certain groups, for example, age, location, or occupation, helps to identify high-risk populations by drawing attention to communities that are disproportionately affected. Having this information can help epidemiologists guide proper allocation of resources, such as hospital staffing, supplies, or other financial support, to inform targeted interventions. In addition, cumulative incidence is helpful for evaluating interventions, since epidemiologists can assess public health measures, for example, isolation, by observing whether the cumulative incidence decreases after implementation. In this scenario, for the Crabapple Valley and Golden Valley Hospital locations, the total number of new cases between August 1st and August 7th was 93 for a total population of 125,000. By applying the formula in the data provided in the scenario, it can be determined that the cumulative incidence of this outbreak is 0.74 per 1,000 people, meaning the overall risk of a person contracting this disease is nearly 1 person out of 1,000. In the Crabapple Valley scenario, the initial mode of transmission was through an infected flea bite Jack received when exploring his new rural property. While inspecting his trees, he observed several dirt mounds. Upon returning to his house, he noticed an itchy red rash and several dead fleas in his bath water. The CDC explains that people can get plague after being bitten by an infected rodent flea, also known as a vector, in an indirect mode of transmission. On July 31st, despite having a fever and other symptoms of plague, he attended 2 local markets where he came into contact with 200 people. At this time, he exposed vendors and market goers to Y. pestis bacteria containing droplets, causing pneumonic plague, which is the only way plague can spread between people and is known as direct transmission. Healthcare workers who came into contact with Jack and others sick with plague also became infected through direct transmission, furthering the outbreak. An effective disease outbreak investigation statement ties into an epidemiological approach to an epidemic by studying the source of an infection, preventing its spread, determining its severity, establishing control over the epidemic, preventing its recurrence, and publishing findings. With this in mind, the purpose statement of this investigation is to identify the causative agent responsible for the sudden rise in fever, lymphadenopathy, cough, and in some cases death among residents and healthcare workers in this area between August 1st and August 7th. By establishing a case definition, conducting thorough case finding, testing hypotheses, and through surveillance, this investigation aims to confirm a diagnosis, determine the source and mode of infectious transmission, and carry out timely control measures to prevent further spread. Investigators will publish their findings to the community and relevant stakeholders to inform future outbreak responses and strengthen local preparedness efforts. Pollitt and Beck explain that a retrospective cohort study is a type of non-experimental research design in which the investigator looks at past events to determine the relationship between an exposure and an outcome. Typical steps in conducting this type of study involve identifying the focus groups from records, arranging them by exposure status, determining which individuals developed the disease, calculating the incidence, comparing risk, adjusting for confounding variables, and analyzing the associations. The purpose of this design is to determine whether an exposure is associated with a later outcome and to assess the risk and incidence of an outbreak. The design is based on a chronological order wherein both the exposure and the outcome events have already occurred, with researchers reconstructing the focus groups using existing data, medical records, public health surveillance data, lab reports, or employment or school records. Researchers identify a defined population based on past exposure status, forming two groups, the exposed cohort and the unexposed cohort. These groups must be comparable aside from exposure to the outbreak. Once these focus groups are identified, researchers calculate the variables using a clearly defined exposure event that has been thoroughly and accurately documented. The outcomes must be measurable using existing data, and any confounders must be identified and controlled to the best of the researcher's abilities. Retrospective cohort studies also incorporate key measures of an outbreak like incidence and attack rates, relative risk, as well as attributable risk. A retrospective cohort study aligns well with the purpose of this investigation because it allows researchers to analyze a past exposure event and determine how it relates to the development of illness. By collecting, analyzing, and comparing data about illness rates, symptoms, and lab findings between exposed and unexposed groups, investigators can identify a higher incidence among those who had contact with the index case at the August 1st farmers markets or at the hospital, supporting the conclusion that Y. pestis was the causative agent. This design also helps identify the source of the outbreak by using existing records to determine who was present at the markets and who later had contact with the patient at Golden Valley Hospital. The higher attack rate among market attendees, followed by a cluster of cases among healthcare workers, helps identify both the primary exposure site and a secondary transmission route. In addition, comparing clinical presentations across these groups helps to explain how the disease spread, for example, through exposure to a flea bite in the community and then person-to-person transmission in the markets and at the hospital. This information allows investigators to distinguish between environmental transmission and clinical exposure. This design also enables researchers to effectively implement control measures by identifying high-risk groups, such as market attendees and medical staff, and by quantifying the attack rates and relative risk. This data informs the scope of necessary interventions to reduce risk, including isolation, PPE, rodent control, or public education. Finally, this design supports the appropriate dissemination of findings by producing clear results that are easy to communicate and provide evidence for reports, press releases, or community updates. A histogram of the outbreak is displayed showing an epidemic or epi curve. The epi curve on this graph illustrates a propagated source, which is an infectious agent that spreads throughout a population in a series of transmissions and represents the time from exposure to the onset of symptoms. This epi curve is significant for demonstrating the timing of the primary attack in purple, the secondary attack in green, the incubation period for each, and a peak incidence date on August 3rd. This data is important to visualize because it supports evidence for an environmental source, offers information on the pathogen's latent state, and helps guide outbreak control efforts. According to Canty and Gottesfeld, understanding the incubation period of this outbreak is critical because the time between exposure to a communicable disease and the onset of symptoms varies and is specific to that pathogen. Knowing the length of incubation and the communicability of a disease is important because this information helps narrow down the cause of the disease, establishing what is causing the outbreak, and informs control measures. This information also helps clarify the disease's latent period when the pathogen is present in the body and replicating, but the patient is showing no signs of disease yet. Canty and Gottesfeld explain that this is also important because the data can help investigators understand whether people can transmit disease during this latency period, how effective control measures are, and communicate this information to the population to protect themselves and others. According to the Centers for Disease Control and Prevention, the incubation period for bubonic plague is 2 to 8 days, while the outbreak scenario from WGU describes an incubation period of 1 to 3 days for pneumonic plague. The graphic on the screen illustrates the onset of symptoms based on the index case in the primary and secondary attack data. According to the CDC's Lesson 1, Introduction to Epidemiology, an endemic disease is one that is frequently present in a population and remains stable and predictable over time, such as malaria in certain parts of sub-Saharan Africa. Meanwhile, the descriptor epidemic refers to the occurrence of a disease that exceeds the expected level for a given region or country. This increase can be sudden or gradual, and the geographic location can range from as limited as a school or town to as large as a country. For example, the spread of influenza in schools in North America during the fall and winter. In contrast, a pandemic is a disease that is spread widely across multiple countries, affecting a large number of people internationally or even globally. An example of a pandemic is the COVID-19 pandemic. The plague outbreak in Crabapple Valley qualifies as an epidemic because the sudden rise in cases exceeds the expected level of plague for the area and is limited to the geographic location where it occurred. The case mortality rate is calculated by dividing the total number of deaths from the disease by the total number of cases and then multiplying by 100 to determine the percentage, or the number of persons per 100 who succumb to the illness. In other words, it helps epidemiologists understand the severity of the disease. In the Crabapple Valley scenario, this number is determined by dividing the overall number of deaths that occurred among the farmers market patrons and healthcare workers at Golden Valley Hospital by the total number of cases at these locales. In doing so, epidemiologists can understand that the mortality rate for this outbreak is 29.03%, or nearly 1/3 of the population that developed plague died from the disease. The World Health Organization explains that plague is a severe disease with a case mortality rate of 30 to 60% for bubonic plague and nearly 100% fatality rate for pneumonic plague in cases that go untreated. This information is critical for epidemiologists to understand as it highlights the importance not only of early diagnosis but also treatment with antibiotics, which significantly improves the prognosis for those infected with the disease. The calculation for a primary and secondary attack is similar to the calculation for cumulative incidence. However, the primary and secondary rates are specific applications of this concept. Instead of calculating the overall risk to an entire affected population, the primary attack is a calculation of new cases that occur in an at-risk population initially exposed to a pathogen, multiplied by 1,000. It helps epidemiologists understand how efficiently the initial exposure caused the illness. As seen above, of the 200 individuals exposed in the primary attack, 62 became infected with plague, leading to a primary attack rate of 310 people per 1,000 exposed. In a similar equation, the secondary attack rate measures new cases among contacts of the primary cases, helping epidemiologists understand how efficiently the disease spreads from person to person. As shown in the slide, of the 480 individuals exposed during the secondary attack, 31 became infected, resulting in a secondary attack rate of 64.58 people per 1,000 exposed. In the Crabapple Valley scenario, the primary attack occurred at the farmers markets on August 1st when Jack first exposed 200 individuals to plague. As the index patient, Jack's illness had progressed from bubonic plague, passed to him through a flea vector, to pneumonic plague. As stated previously, the pneumonic form is the only version of plague that is transmissible from person to person. Of these 200 people, 62 contracted the disease. The secondary attack occurred after August 1st as infected individuals pursued care at Golden Valley Hospital, further exposing an additional 480 healthcare workers and staff through person-to-person droplet transmission. Of these individuals, 31 people contracted the disease. The findings discussed in the previous sections help inform control measures that are effective for the Crabapple Valley outbreak. Because the evidence revealed that both vector-borne transmission was initially responsible for the disease entering the population, and then person-to-person spread became the primary mode of transmission, these control measures must address both pathways. Because pneumonic plague spreads through infected respiratory droplets, the CDC recommends the use of personal protective equipment, or PPE, especially face masks. This measure is essential for limiting the spread of person-to-person transmission during the outbreak by reducing exposure to infectious droplets and protecting close contacts of those who are symptomatic. Additionally, the CDC recommends isolating symptomatic individuals to limit the spread of disease during its communicable period. Quarantining exposed persons is also appropriate because, as seen earlier, the incubation period for plague is relatively short, and early identification of symptoms is crucial for both preventing future cases and ensuring prompt treatment, which can improve prognosis. This intervention aligns with the research study's goals, which hypothesize that attendees of the farmers markets have a higher risk of contracting the disease. Finally, the CDC also recommends rodent control within community spaces by removing brush, rock shelters, firewood, and junk piles, which addresses the initial environmental source of the outbreak. As the first case was transmitted via an infected flea bite, it is reasonable to assume there are more infected fleas within the community. Removing the desirable spaces for rodents in high-traffic areas, which serve as carriers for infected fleas, helps prevent additional flea-to-human interactions. Disseminating an information plan about the outbreak to the public, relevant agencies, and key stakeholders involves three critical themes. These are: who is responsible for informing these parties, how the information will be communicated, and how frequently data will be updated to best serve public interest. First, individuals most familiar with the investigation and its findings, such as epidemiologists, researchers, physicians, nurses, and other public health officials, are best suited to communicate outbreak information, which ensures that messages are accurate and evidence-based. Authority figures who can enact legal policies, such as regional leaders, should be fully informed to implement necessary public health interventions. Next, the information will ideally be communicated in a way that is concise, consistent, and free of medical or technical jargon, ensuring that diverse community members can all understand the materials that are made available. Multiple platforms like printed copy, local news broadcasts, radio announcements, and social media can be used to cover large geographic areas. Distributed materials should merge elements that promote accessibility, such as closed captioning or visual aids, to support individuals with disabilities, those with limited English proficiency, or those with low health literacy. Finally, the frequency of communication relies on the most current fact-based information available. These messages should include next steps, successful efforts, and any changes to outbreak control measures, maintaining transparency to encourage public trust and confidence. The average reading level in the United States is between 8th and 9th grade, with more than 25 million Americans reading at a level below a 5th grade level. With this in mind, messages should be delivered at approximately a 7th grade reading level and with an attention span that matches to ensure comprehension and accessibility and to include vulnerable populations. In working through this project, I gained a deeper understanding of the numerous coordinated steps and crucial individuals involved in an outbreak investigation. Epidemiologists, lab teams, nurses, doctors, and public health officials all play key roles and must work together to effectively manage an outbreak. Calculating and interpreting cumulative incidence in primary and secondary attack rates greatly helped me reflect on and identify the most at-risk groups and why this data is important when implementing control measures. Related to this, visualizing incubation periods through constructing the histogram and epi curve helped me understand how disease transmission patterns can shift over time. Although challenging, designing an outbreak investigation purpose statement helped me learn how to integrate several early investigation concepts into one cohesive piece. If I were given the opportunity to investigate an outbreak again, I would take into consideration how quickly information can evolve and approach the situation with more flexibility. Working through this scenario reminded me that the ability to adapt case definitions and communication strategies as new information becomes available is very valuable. In real time, this translates to staying open to hypothesis revision and adjusting my responses as new evidence becomes available. The application of these concepts to my current clinical practice strengthens my abilities as it reinforces the importance of communicating health information in a way that patients can easily understand, which supports informed decision-making. Learning about the critical importance of incubation periods prompted me to reevaluate my prioritization skills and responses to evolving clinical situations, enhancing my competence both in the hospital and in the field. I hope you appreciated my presentation, and I thank you so much for taking the time to go through it with me. Thank you.